Okay, so now we're looking at management. We're going to carry over endometriosis and adenomyosis to the next slide and discuss them together. But in terms of chronic PID, your first step would be to treat with the usual triple antibiotics, as well as a partner letter. And if these don't help the experience of pain, or if fertility is the main concern, then you will need to refer, because this patient may need surgery for adhesiolysis and an infertility workup to look at the tubal patency, etc. Surgery for adhesiolysis, we will talk about a bit more on the next slide, but it's not always ideal, because when you go in there, you are with your scalpel causing more trauma, and you can end up causing more adhesions. So previous pelvic surgery is in fact a cause of chronic pelvic pain because of adhesions. So we do try and avoid that as much as possible, but if it's necessary, it's necessary. And then in terms of IBS, so you might not be sure what's going on with the patient unless they've got these very clear patterns that we've described for the other issues. If there are some bowel symptoms, then you can try and manage this as IBS with advice on a high fiber diet, to increase water intake to 8 glasses a day to keep the stools nice and soft. And you can try Buscopan, which is the smooth muscle antispasmodic. You can try for 10 milligrams TDS for up to 3 months in a row to see whether that makes any difference. And if it does make a big difference, then you know that that was the reason that this person was having pain, and you've made the correct diagnosis. A key message here is that you need, for IBS, you need an extended period of time to see whether the intervention is going to work. Okay, and now my slides are stuck. Why are my slides stuck? There we go. Okay, endometriosis and adenomyosis. Please, for heaven's sake, if a woman tells you that her period pain is interfering with her schooling or her university education or her job or her ability to parent or her relationship, please do not disrespect her by telling her that this is normal and this is just something that she has to live with. The average time that it takes to have endometriosis diagnosed is 10 years. So Matilda and Lumisa's stories are based on statistics. Please do not ignore what your patient is saying to you. It is really unbelievably incapacitating, and it can ruin lives. What you need to do in terms of medical management, and this is something that you can try. So if you are in the middle of nowhere and it's going to take months and months and months for a referral, and you've got the history and examination that very much feels like adenomyosis or endometriosis, what you need to do is flatten the endometrium. And you can do that with any hormonal method that would be appropriate and safe for that patient. You need at least 3 months. So if you're going to use the pill, you need at least 3 months of the pill before we can determine whether it's actually going to make a difference or not. And so you would follow them up 3 to 4 months after you've started this intervention. As with fibroids, it does take a while for the whatever method to actually start being effective. And probably one of the main reasons they've come to you is because of the unbearable pain. So you need to manage the pain, and you need to manage it aggressively. You need to manage it with 3 different agents that are to be taken by the clock every day that that woman is having her period, unless she feels that she doesn't need it. And I'm going to show you what a prescription would look like in a minute. If they do respond to hormonal methods, that is diagnostically helpful, because if you do thin the endometrium and the symptoms decrease, then you know you're probably on the right track. You do need to explain to them, especially women who've been having these symptoms for many years and who might have adhesions, you need to explain to them that you might not be able to take their pain away completely, but you should be able to make a difference. You should be able to allow them to live a more comfortable life. Remember, with adenomyosis, one of the main issues is bleeding. And for that, as with fibroids, we would use tranexamic acid to be taken during the periods only. So here is a little prescription for analgesia. and this is what I routinely give to anyone who's got endometriosis or adenomyosis to take when they are having their periods, unless obviously they've got a contraindication. So some people, for example, people with severe hypertension or an allergy to aspirin or ibuprofen, you can't give ibuprofen. Some people have side effects on tramadol that are just not acceptable. So you do have to counsel patients. Tramadol can make you feel dizzy. It can make you feel a bit high. It can make you feel nauseous. People will normally become tolerant to those side effects. But if tramadol makes somebody vomit, then that is a drug that they cannot take. They're just not able to tolerate it. But in an ideal world, you give those three medications together. Paracetamol and ibuprofen potentiate each other, so they're always given together. And tramadol is a very safe but very potent opioid that we use for pain. So this is how severe the pain is, guys. This is what we need to do to control the pain. Yeah. Oh, a piece of advice for people who are taking tramadol for the first time: because of that wooziness and dizziness, you should take it when you know you're going to be at home and relaxing and sitting down, so that you see how it affects you. You can't take it on a morning where you know you've got to go out to work or go to the shops or whatever, because you're not sure how your body's going to respond. Okay, and then you put enough repeats on there to last until the next follow-up visit. The aim is to get someone to a point where they no longer need the analgesia, but you go at it pretty hard in the beginning and you make sure they have enough repeats. If she has got bleeding because of adenomyosis, you are going to add the tranexamic acid, bare minimum 1 gram 8 hourly times 5 days with periods, and that will be added to all the analgesia. You can see that they're all 8 hourly. Okay, so that is quite convenient. If the bleeding is really severe, you can go up to tranexamic 1 gram 6 hourly, but then it's out of sync with the other medication, which makes it a little bit more difficult to take. And you also give enough repeats. You're anticipating that the bleeding will improve with your hormonal intervention, but you do need to give enough repeats to get to that point. When to refer? Well, if your hormonal measures and analgesia are not helping, then this person needs to be referred for tertiary assessment. In tertiary care, there are various options. Some of the primary care centers don't have Mirenas available, so sometimes that is one hormonal method that's still open to us at hospital level. For really severe symptoms that haven't responded to anything, we could consider Zoladex, which is a GnRH agonist. That is not something that you can be on forever, because it renders the woman in a postmenopausal state, which has quite significant impact on bone density, etc. So we can only use that for about 6 months. And they might need an exploratory laparoscopy or surgery for adhesiolysis, noting the complications of that I've mentioned before, that we try and avoid surgery because it can create more problems. You would also refer if fertility is the main issue, because what you're able to give is hormonal contraception. So you might be able to negotiate with the patient to go on contraception for symptom control while you await a referral, because it will help the referring doctor to see whether this has responded to hormones and therefore we're on the right track. But some people are just absolutely adamant that they don't want any form of hormonal contraception. Then you would just give them the symptomatic management of the pain, the analgesia. And like with Matilda and Mumisa, women who experience chronic pelvic pain, and in fact people in general who experience chronic pelvic pain, often have multiple psychosocial issues happening in their lives that impact on their experience of the pain. So if they are very depressed or having a lot of relationship issues or things like that need more of a multidisciplinary team, then you would also refer. Dr. Kennedy at Somerset has a chronic pelvic pain clinic, which brings in things like meditation and different forms of pain management that are not necessarily traditionally medical. So yeah, if there are a lot of other issues, then you might need to refer. But the bottom line is that this is quite a crippling condition, and you cannot dismiss this kind of dysmenorrhea as just your average normal period pain. Okay, and that's that.